gentlemen, we have two discussions to be had today. The first one starts with a procedure, something called as a bowel preparation in surgery, and we'll like to have it in a very straightforward answer, like the way a resident is asked in an examination, or like the way a resident is going to be asked by maybe his senior in a round about what is his observations on a bowel preparation. Now, we'll start with very straightforward things. One, to begin with, what is bowel preparation? Now, what is bowel preparation is something that you need to understand. And this means that the normal colon, we are not talking about the stomach. We are not talking of the small intestine like the duodenum, etc. Because we know that surgeries in these two areas, particularly the stomach, has acid, and the upper part of the small intestine is less number of bacteria. So the amount of a surgical site infection or the amount of say wound or anastomotic leaks are usually not related with the quality of the content or the quantity and the quality of the content. Now, this has been an observation since around many years. So people were not very worried about that this is going to be the status of things. But when it comes to the colon, remember, contains a solid, semi-solid, and liquid fecal matter. Always, definitely, along with it will contain some amount of gas, which can sometimes be even combustible. So the main points are that while you are doing an operation on the colon, the main observation points to discuss are that we need a clean operative field. We need a clean operative field with no spillage of contents, because the colonic contents contain crores and crores of bacteria. Number one. Number two, it is said that anastomosis is done under vision and with an idea that the contamination of the anastomosis is minimal. So the last point is that if you need to see for mucosal lesion, mucosal pathology, particularly if you are planning to do a intraoperative colonoscopy, then definitely you need a clean bowel. But out of these, what has been done is that time has shown that this, and these do not have any proven statistical advantage. I will not add the word science, because science is what we think and what we practice, and we try to have a logic behind that. But there are umpteen number of studies and meta-analysis, particularly the most quoted one is the Cochrane data, which has shown that there is no particular advantage about these. On the other hand, there are data which have proven that it may sometimes be associated with more chance of an anastomotic leak, delayed function of the bowel, and definitely in the times when we have talked about enhanced recovery after surgery, this kind of a bowel preparation is not at all encouraged in patients who are in the ERAS protocol. But there is only one thing that has stood the test of time, that is the fourth indication. This, believe me, is still a valid indication about when to prepare the bowel for a intraoperative colonoscopy. Now, if you are thinking about that as a surgeon, is bowel handling easier is bowel handling easier if I prep the bowel? Now, the answer to this one is maybe, may not be. Now, may not be will be particularly very important if it is a stricturing lesion, because obvious reasons. The stricture is going to hold up the liquid feces, so it is a contraindication to prepare a bowel. Maybe, but the question is it really worth it? Because in the times of laparoscopic colectomy, remember that the specimen and the anastomosis, whatever you are trying to do, say for example, you are trying to do a stippled right hemicolectomy or a stippled LAR, then remember that majority of these times you will require a stapler to be put. And whenever you are considering a stapler or a stapled anastomosis, then the only concern is that spillage, whatever it is usually minimal. But all said and done, these are what evidences are about. The next question is, do people practice bowel preparation, or that means colon preparations? The answer to this is, in a theory, they always preach that no, we do not believe, and there are Cochrane data with umpteen number of evidences which prove that they may not be beneficial. But what is important is, in a real world and in a real practice, when you talk about people practicing and preaching about this, then a majority of surgeons still now believe in some form of bowel prep. Now, as I have said, it all depends upon what is the type of preparation, but they believe in bowel prep. Definitely, we are not talking emergency. We are talking of an elective surgery. Now, what happens if you talk about an emergency situation? Do you need a bowel preparation? The answer for this is no, you do not need a bowel preparation. But what has been the previous thought is something called as an on-table colonic lavage. Now, what is an on-table colonic lavage? Now, we have practiced around a couple of them in an emergency setup, and believe me, you will understand what is the problem. Now, on-table colonic lavage was popularized by a gentleman called Dudley in around 1970s to around 1980s, only for a left-sided colonic obstruction, in which if you are planning to do a one-stage procedure, what do you mean by a one-stage procedure? It technically will mean that you are planning to do an resection and an anastomosis. So the basic idea is that say for example, there is a growth in the rectosigmoid. Say for example, there is a growth in the rectosigmoid, and you believe in excising the growth in a primary fashion, which you can do. It is not that you can take a 5 centimeter margin, you do an oncological clearance, and then you have done an excision of this one. Okay, so we have understood that. Now the main question is that now this is one end and this is another end, and you want to anastomose these two ends. You have mobilized the descending colon, so you are now ready to do an anastomosis. And then when you are ready to do an anastomosis, you have one point of concern that is very, very obvious. And your assistant says that, sir, the whole colon down the line appears to be loaded with fecal matter, which has formed because it has been a stricturing lesion in the left colon, and this whole colon and the whole liquid fecal matter is dilating the bowel, whereas this end is more or less very clear, and as it would have happened distal to the stricture, there is no content in this. So the only question is, the minute you open the clamp and the minute you think about removing the clamp for the anastomosis, maybe You are very worried that the anastomosis will be subject to around 5 liters of liquid fecal matter. If there is a leak, it is a sure shot recipe for a peritoneal abscess and death. So the main proposal that was put in by the gentleman was that God has given the vermiform appendix, and the vermiform appendix with the meso appendix is important. And then what is expected is that in this part you excise the tip of the appendix, and when you excise the tip of the appendix, please see this picture. We have understood that this is the tip of the appendix, and through this insert a Foley's catheter and put a warm normal saline, around 3 to 5 liters of normal saline. And with this, before you open the clamp, you attach a tube, maybe an anesthetic circuit tube. Tell an anesthesiologist, have a cup of tea, and then by the time have one of his tubes, and then have a bucket, and all the contents are now, all the liquid fecal contents are in the bucket. Believe me. So this is all about, and everyone in the OT is screaming at you, particularly the theater nurses are screaming at you, because like the procedure that we have felt was that our limiting factor sometimes became how many buckets we had in the theater. So it appeared to be a very cumbersome procedure, but at the end of 5 to 6 liters of water or normal saline, the colon was technically said to be cleansed, and then we could do an anastomosis. But the only problem was that there were studies after and after this one, which have proved that no, it is not essential to do this. If you can do a proper watertight anastomosis, taking the proper principles of doing an colonic anastomosis. So if you talk about that, what is the main philosophy? That the main philosophy is that there is no role of intraoperative bowel preparation, or better called as an on-table colonic lavage, in the present era. If you are planning to do a primary anastomosis, be my guest. Please do the primary anastomosis as such. So the leak rates will be as with a bowel prep, maybe a little lesser than a bowel preparation as would be. So this is emergency. We will now talk about a elective scenario. And when we talk about an elective scenario, as we have said, bowel preparations are more or the less a practice rather than, as I've said, this is more of a practice than this. So what are the agents that we use for bowel preparation? Now, the better thing about agents that we use for the bowel preparation are then better called as, so what we'll try to do is that we'll try to classify them, because people have asked this about these classifications and what are the things to know about this one. Okay. Now, so what are important things are that the agents that are used in the bowel preparation are something called as an MBP. So the word MBP will mean mechanical bowel preparation. Okay. Now, what is also important on another side of the story is oral antibiotic bowel preparation. So there are two sides of the story. One is mechanical and one is oral antibiotic bowel preparation, because people feel that not only cleansing the bacteria helps, but also adding some antibiotics to kill the bacteria should also be important. Now, so what are the important agents that we know, and what are the various agents that can be given? Now, when you talk about various agents that can be given to do a mechanical bowel preparation, they can be given either orally or they can be given rectally. Now, when it is given rectally, definitely it is called as an enema, and orally there are various forms of giving it orally. So what we'll try to do is that we'll try to make it into important ones, and we'll try to divide them into various categories to see what are these and what are the roles about them. Now, when we talk about the oral drugs, the first of the oral drugs to begin with are something called as osmotic, catharatic. Now, that means that they are expected to draw in the water. Okay, so they are osmotic catharatics, and they are usually absorbed, and they will be then responsible for bringing in the water. Okay, now when you talk about the osmotic catharatics, okay, is something that is the next ones are the best examples of osmotic catharatics will be sodium phosphate, okay, which is usually present in the form of a tablet. The mechanism of action will be that sodium phosphate is going to act by drawing in the water. And what is important is what is the dose is dependent upon that. That definitely there are various regimes that are usually advised, like say around 3 tablets every 15 minutes to a total of 20 tablets, etc. And so it all depends upon, but usually the material is either in tablets or it is sodium phosphate. This is something that we use, and our colonoscopy guys use that, is usually in a liquid or in an aqueous form. And that aqueous form is usually around 50 ml. And what is done is that this is usually added with the cold drinks, and the patient is given a hour around. This is repeated around 10 hours later. So if you need a bowel preparation today, you need to give it the day before in 2 doses, maybe around 7 o'clock in the morning or around 4 o'clock in the evening. So this is what is usually the regime about what they usually will say about an osmotic cathartic. The main problem with this phosphate story is that phosphate will have its concerns in patients with renal failure. So these are the main problems about, and patients with a kidney problem will have a real challenge with this one. After we have talked about osmotic catharatics, the second agent is something called as non-absorbed osmotic agents. Now, what do you mean by this non-absorbed osmotic agents? Now, like phosphate, which comes into the blood and kidneys may be affected, what is more popular is something that stays and it does not say do anything to that. So that means what people have done is that definitely the first one that comes into our practice is something called as polyethylene glycol. We all know the name and goes by various names like Golly, Telly, Peg Lake, etc. Okay, so polyethylene glycol or PEG is a very favorite one. And what is important is that how is it given? Now, polyethylene glycol is, there can be various preparations into that. Okay, so either it is used as a sachet or it is used as a liquid. It can be a 4-liter solution. It can be a 2-liter solution with electrolytes, without electrolytes. People can be taking 4-liter as a single dose. It can be taken around in the gap of 2 liters and 2 liters. But basic idea is that it has to be given at least 12 to 16 hours before the surgery. And after the drug is given to the patient, then the patient is told that there will be lots of bowel movement. You need to drink a lot of ORS water, which is going to take care of the electrolyte problem. So people have added electrolytes to the polyethylene glycol also. So this is the second preparation that is a very common one that more or less everyone will have. The main issues here are dyselectrolytemia and dehydration, which definitely needs to be corrected. People have worked around with 2 liters and 4 liters. There are no differences between them, but usually it is all dependent upon the patient to have had and this. Now, So if these are the basic agents about osmotic catharetics, non-absorbed osmotic agents, we come to the third category. The third category is something called as a stimulant agent. Now, a stimulant laxative is something that is known to kick the bowel and do the action, or better called as a contact irritant, a contact irritant of the bowel. What is this contact irritant? The best of the drugs that are known are bisacodyl. The best of the drugs to know in the practice is something called as bisacodyl, in which it is a single dose of around 2 to 4 tablets. Each tablet is around 5 milligram in strength and is taken in a single dose. So this is a very common preparation that is used, particularly if you are doing an rectal or an anal procedure. Okay. Now, people have combination drugs. Combinations can be of various kinds, and you have known that in your practice. In the combinations, we can combine sodium picosulfate, and so we can combine, what we can combine is that we can combine sodium picosulfate, okay, and along with sodium picosulfate, we usually will give a magnesium citrate, okay, magnesium citrate. And please remember that the sodium picosulfate and magnesium citrate, the magnesium citrate acts as an osmotic agent, whereas the sodium picosulfate will act as a stimulant agent. So these are combinations that are given. Now, there can be combination number 2, which is a very interesting combination in which you combine the polyethylene glycol and add an bisacodyl to this. Okay, so these are various preparations which have been given in this, with only one idea, that the bowel needs to be clear of the colonic contents. Now, rather than talk about the advantages, what are the other agents that can be used in the rectal route? Now, in the rectal route, there are a few things. Example being glycerine, which is a very common agent that is used in the rectal route as an enema. Then lactulose can be used as an enema. Lactulose can also be used in the oral route, which is a routine laxative that is prescribed. Okay. Sorbitol is usually used in the oral route as a laxative. So these are the various ones that are used in various points to know. Particularly the role of glycerine is usually used as the agent. After we have talked about this, what are the disadvantages and why is it not very preferred? Or why is a mechanical bowel preparation not preferred? We have talked about why is it preferred. Now, why is it not preferred? Now, the problems of these to begin with to a surgeon are, there are a lot of metabolic disturbances which are really unwarranted in patients who already have a fragile maybe metabolism due to kidney problems. What are the problems that you can land up with? You can land up with hypernatremia, you can land up with hypokalemia, you can land up with hypocalcemia, you can land up with hyperphosphatemia and metabolic acidosis. So you can land up with these electrolyte problems, which are common ones. The second one is there is a delay in the return of the normal bowel function. So there is a delay in the return of the normal bowel function. So this is what is a big problem in the delay. Apart from this, what happens is that there is a relative increase in the urea concentration. So patients who have a renal disease, for them, this may be a difficult one. Number 4, the compliance on the band of the patient or on the role of the patient is very poor, because it is a form of a discomfort to the patient. Dehydration is really a very big problem, as well as abdominal distension and abdominal cramp is a real big problem. So these are the main issues to know in these patients. And this is the reason MBP is not preferred in this patient. So this is the main issues about what is a mechanical bowel preparation, what are the types of a mechanical bowel preparation, and why should you be doing this, why should you not be doing this. As I have said, if you talk about what are the evidences that we have had about the various outcomes, then comes a role about oral antibiotics in the mechanical bowel preparation. Now, when you talk about oral antibiotics in the mechanical bowel preparation, as I have said, the basic logic about oral antibiotics is very simple. That means not only is the mechanical cleaning of bacteria required, you need to also give some antibiotics. Now, the most of the preferred regime called as the Nichols regime was adding neomycin and erythromycin. Gradually down the line, there were many other regimes that came up, like cotrimoxazole plus metronidazole. Okay. The next came something called as neomycin plus metronidazole. So there were many other regimes that were followed, but this is the main logic in this that were used. So if you have seen the colorectal society guidelines, majority of them will not favor a mechanical bowel preparation in the time of enhanced recovery, because as I have said, it is not at all with any of the modern evidences which support this one. So there are multiple n number of studies which we can quote about that in the current practice, majority of the societies are not going to give this. What about the role of enema as a preoperative preparation, as I have said? Now, enemas about these ones will always be, remember about enemas in these ones will always be agents like sodium phosphate, glycerin, and saline. So sodium phosphate, glycerin, and saline, which are used, and then these are used usually 2 to 4 hours before surgery. These are used 2 to 4 hours before surgery as a part of their use. Now, the majority of them will usually be for procedures in the anal canal, like again, fissure, piles, fistulas, etc. Okay, so this is usually done for them. Now, there is no difference, as I have said, again, in procedures of anal canal and then, but still, majority of surgeons will prefer them in this. Now, let us talk about the final words and let us talk about the current practices. Now, current practices, as I have said, is that they do not favor, the current practices do not favor any mechanical bowel preparation. Okay, so any of the societies, they do not usually favor them. So, and then there has been more of chances of anastomotic leaks than having a mechanical bowel preparation. Okay, so these are the points that finishes about this discussion. What are the usually dietary regimes that the patients are required to follow? The conventional teaching was that from 3 days ago, you tell your patients not to take any heavy or any fiber containing food, particularly those who have a history of constipation. That's 2 days ago, you tell your patient to increase the water intake and omit the fiber in the diet. one day ago, you tell your patient to have an adequate number of water in the diet and to take semi-solid food. Now, these are all conventional thoughts which have all been challenged in the times of an enhanced recovery, because people have thought that around that this does not have any of the logic to have it. So the role of low residue supplements, etc., have always been challenged. So it is important that mechanical bowel preparation is not favored now. I will repeat this many times, except maybe if you are planning to do an intraoperative colonoscopy. Now, how does this practice changed? Now, if you are planning to do that, I need to see the rest of the bowel and I need to do a polypectomy. Maybe that you need to do a polypectomy around this, and you are not very worried that, or you are worried that I am doing a left-sided resection, and with this colon I need to put in an endoscope. How will the colonoscopist see that polyp? The point is that, or if I need to do a segmental colectomy maybe. So what the colonoscopists nowadays they do is that if you are planning to do 2 resections in the bowel, they will produce a tattoo on the mucosa. So laparoscopically, you are able to see. I'm not telling you to palpate. This is the growth that has been tattooed, and you can go for a resection. Maybe you need a polypectomy also, or you need a segmental resection, not a standard subtotal colectomy. So maybe for this way, you can have a tattoo and you can do your job. So guys, I think we'll be ending at this point. Okay, so this is all about mechanical bowel preparation. Okay, right. Thank you. I'll be taking your questions now.
Sir, in fistula surgeries, can we use this bowel preparations?
Sir, as I've told you, if you are using it for anal surgeries or piles, fissure, fistulas, etc., so evidences do not favor them. But definitely, if you ask me what is my practice, I believe in the patient having a light, low residue diet around 2 to 3 days ago. The day before, I tell the patient to have an enema in the evening, to have a little amount of rectum which is cleared off of the fecal matter. And then again, when the patient is shifted to the OT, at least 3 to 4 hours before the patient gets an enema. But as I've said, there are no technical say evidences that go in that favor. So if you're planning to find a fistula surgery, or maybe you are planning to do even maybe a sphincter reconstruction, well, there are no evidences that support the use of this, but majority of surgeons will still do that. Okay.
Sir, if in the examination they ask about our take in mechanical bowel preparation, what should we answer?
In theory, as I have said, there is no role by any chance. All the evidences starting from last 10 years have all gone against a bowel preparation as a part. Every of the evidences have gone just against a bowel preparation. Okay. So there is no role of doing a bowel preparation, sir. But in a Viva, if you are asked this, definitely you may be asked this in a Viva, that what is the role about this? What is your thoughts about this one? Then you may say that, sir, we have read in theory that there is no particular advantage of a bowel preparation, but if you are following that in your unit, you may please narrate whatever is your practice. But the only point is that there is no rationale in doing it in the right colon, because the contents in the right hemicolectomy are always liquid. So even if you do a bowel preparation, it is going to remain the same picture. Now, talking about the left colon, the story is going to be very different. In the left colon, the main issue is that there will be semi-solid fecal matter, and maybe if your unit's practice is to do a bowel preparation for a left colectomy or maybe an LAR, then you are free to talk. But avoid a bowel preparation in a near stricturing lesion. Remember, that's a very big trap. If you do a bowel preparation in a near stricture in the rectosigmoid, that bowel is overtly distended, and that is technically very difficult to control. Okay, right.
Thank you.
Okay then. So I think we'll be taking a 5 minutes break, and then after that, we'll be starting the next class on food. Yeah.
Yes, sir. Sodium phosphate tablets, how much to be given, sir?
Sir, that depends upon. Usually, if you ask me, the doses will be around now. That depends upon what is your unit's practice. It is around for a total of around 20 tablets. Repeat thereafter by around 20 tablets, and then it is usually given in multiple tablets. So to remove all these tablet problems, it is better to have that liquid. Liquid is a much more tolerable. If you tell your patients to take 40 tablets around for a gap of around 8 hours, the compliance, I think, will automatically go down. People are not very happy taking so many tablets. Okay, right there.
Hello.
Yeah, go on, sir.
Is there any specific amount of delay in the bowel normal bowel what?
See, the main point that you are asking is that when should you be giving the tablets for the operation? We are presuming that the operation is posted at 8 o'clock in the morning, like all the theaters in the world will be doing. Like you may be also posting your theaters around 8 o'clock in the morning. Let us presume that this patient has the first operation of the day. It is not an anal procedure which is usually pushed to the end of the day. So the major point is the patient's last bowel movement should be have had around 3 to 4 hours, at least 2 hours before the procedure. Now plan on that one. If you need to give an additional enema, plan it 2 hours before so that the patient is in comfortable state.
No, sir. You said that there is a delay in return of normal bowel function. Is
So
there any
how much is the delay? No, sir. That is something that you and I cannot predict. That all will depend upon many factors, starting upon the complexities of operation, the post-operative contamination that was done, whether it was an open or a laparoscopic procedure, what is the electrolyte status in the patient post-operatively. But overall, it has been shown that people who have had a mechanical bowel preparation, for this group of patients, this group of patients, return of bowel function has been not a very, very strong studied material. But if I think about on the other sense, two major problems. I talk about anastomotic leaks. Majority of them with an anastomotic leaks, like there are multiple series, majority of them, except a few, have shown with a statistically significant point that anastomotic leaks are around twice that of in a mechanical bowel preparation versus those who do not have a mechanical bowel preparation. I have not told about drugs like mannitol, which are absolutely not used now, because mannitol used to produce a lot of methane and people have stopped using mannitol. Some people use something called as Senna, SENNA, which is an herbal medication that was used by many senior people. Again, they are not usually used, but some people may be using that. Cancer patients may be having had a povidone iodine enema. Now again, that may be a local practice, but majority of you will be doing either a sodium phosphate or a polyethylene glycol and maybe an enema as a saline or a glycerol. Okay. So sir, this is all the points about these ones. But what happens is that both wound infection rates and anastomotic leak rates are more with MBPs rather than not. So please remember this.
Sir, you have right now mechanical bowel preparation is not favored. I agree with it. But what about only oral antibiotic bowel preparation, sir?
Like you can give that. Will you be calling it as a bowel preparation then?
I would not generally give it in a cholecystectomy patient. No. I know.
Now see, if you give an oral antibiotic preparation, your point is well taken. Now you are asking me that if I give a patient, for example, rifaximin, which is going to stay into the lumen of the bowel, and then you need to give, your main idea is that I need to cleanse the colon with rifaximin. I do not think that's a very logical one, because oral antibiotics will, see, the main reason you are giving an antibiotic is to prevent a sepsis, either localized or generalized. Now, if you are planning to do a colectomy, the nature of the operation will immediately be a class 3 or a class 4. It will either be a contaminated or will be dirty, depending upon what is the operation that you are going to do. You are not going to classify colectomy as a clean contaminated ever, because you know there is going to be a lumen that is going to be opened. So definitely this patient is going to receive a dose of prophylactic antibiotic and followed by a post-operative course of antibiotic, maybe for 3 to 5 days, till the patient's requirement for or leukocytosis settles down, etc. So this is the main point to remember. But definitely if you're asking me oral antibiotics, no sir. There is no particular evidence of use of an oral antibiotic that will be helping.
Thank you.
Okay. Right. We take a 5 minutes break.